This is Sg2 Perspectives, a conversation with Sg2 experts and industry thought leaders about the biggest trends in healthcare and what we expect that's going to mean for the future of healthcare delivery.
Hello and welcome to Sg2 Perspectives. I'm your host, Tori Richie. Today we are talking all things PEDS as it relates to the 2025 Impact of Change forecast. I am joined by our pediatrics team, Rhae, Gamber, and Dionne, Cruz. Thank you so much for joining.
Thanks for having us.
Thank you.
Rhae, I'm going to kick the first question to you. Looking ahead, why do children's hospitals show forecasted growth within the new projection numbers versus non-children's hospitals, which are declining?
Let's start with a quick overview of what those numbers actually are to give everybody a sense of our forecast. This year, our overall pediatric discharge forecast for the 10-year timeframe is -3. So it is negative. But within that, we do forecast what will happen at children's hospitals and what will happen at non-children's hospitals. We forecast this care shift from non-children's hospital or community-based pediatric programs to children's hospitals. Think your tertiary, quaternary centers of excellence. We have our children's hospital forecast growing 2% in the 10-year timeframe. So it's relatively flat, soft growth, while our non-children's hospital forecast declines 9%. So that's driving the decline that gets us our overall decline. But that care shift from non-children's to children's keeps children's hospital discharges afloat. We will sometimes talk to children's hospitals and they'll tell us this regionalization, this shift from non-children's to children's hospitals has already played out in their market. They don't really think there's more room for shift. But when we look at the numbers, we're always surprised to see how many pediatric discharges still happen outside of what we think of as a children's hospital. Even if there's not even a dedicated pediatric unit somewhere, we still may see some pediatric discharges there. We have continued this care shift in our projections. We still do see opportunities for care to shift from community-based programs to children's hospitals, but that is happening in a couple of different ways. One, of course, we are seeing community pediatric units closing. There are financial pressures. There is a lack of pediatric expertise out in the community workforce, and that's the traditional driver of this shift. But there's also this second trend where we're seeing children's hospitals expanding their footprints and elevating the level of care that is provided out in communities. For example, Cincinnati Children's recently announced a plan to build a new hospital in Indiana in partnership with Parkview Health. So in the past, they may not have considered Parkview Health like a traditional children's hospital, but in the future, we certainly may because of these investments that children's hospitals are making out in communities.
We talked for a number of years about declining birth rate, and that's contributing majorly to that decline in pediatric discharges overall. But how do we then reconcile the growth that we are seeing in that children's hospital cohort? Where is that coming from?
Birth rate decline is one of the big downward pressures on our overall pediatric forecast that ultimately does give us that -3 overall number. But there are some other downward pressures in addition to birth rate decline. There's the RSV monoclonal antibody that will reduce utilization and the number one cause of infant hospitalization today. We've already seen that play out last year where we had a relatively low RSV season. We also see quality initiatives, reduce readmissions. We have innovations and technologies that will drive fewer surgeries per patient. We have drugs that will cure disease that promise to reduce utilization as well. So these are all downward pressures. But your point is we still see a positive forecast to children's hospitals. That is in part because the fewer children that we do have in the pediatric pipeline are sicker. They're utilizing higher levels of care. They may need more stays to manage their condition. They're utilizing the ICU more. They have comorbidities, unfortunately. Also, with all of the innovations I mentioned, with that come survivorship gains. So children utilizing more care than they may have in the past. We also see children's hospitals are taking on more of the behavioral health capacity in the United States. Almost every children's hospital I talk to has added psych beds and they're bulking up their inpatient care delivery there, taking over more of that. And that's what drives a lot of the growth, especially in the short term. And then finally, some of these emerging therapeutics that I mentioned, while they do promise to reduce utilization in the long term, they have intensive delivery mechanisms at times that will keep children inpatient. So all of these things work to keep that more flatter forecast at children's hospitals.
That makes sense. It's a similar concept to what we talk about on the adult side of the spectrum, where if folks are continuing to show up to that inpatient facility, what's left in that inpatient facility is continuing to grow for those variety of reasons that you listed out. If we think then about what is happening on the outpatient side of the house, Dionne, could you give us an overview of what some of the growth opportunities are for PEDS in the ambulatory environment?
I'll build off about children's hospitals investing in building out capacities. In the outpatient setting, it's not surprising that behavioral health is seeing some of the strongest outpatient growth. So we're talking in the double digits. It's pretty clear at this point that behavioral health is a core need for pediatrics. The demand has just been so high that it's really reshaping how children's hospitals think about delivering this care. A lot of children's hospitals have made a lot of strides in the last few years in weaving behavioral health across the system of care. Everything all the way from training pediatricians and embedding behavioral health therapists into the pediatrician office to opening med-psych inpatient units for patients who may have comorbid physical and psych conditions. The next phase is really about continuing to expand all of those outpatient access points like partial hospitalization, intensive outpatient programs, school partnerships, community-based programs, thinking of these as not just as an alternative to inpatient or to crisis care, but really as that first and foundational point of access for early intervention and also ongoing care.
Are there any additional service lines that offer robust growth opportunities within the outpatient space?
Other areas where we're seeing growth in the outpatient space is GI. Here we see growth in the infusion landscape, specifically for conditions like IBD, where we expect biologics to contribute to growth in infusions for this patient population.
So interesting to consider the impact that the pharmaceutical innovation is going to have on downstream demand. And if we're already dealing with a finite number of resources and we're already feeling capacity constrained, what are practical steps that organizations can take to help navigate this challenging capacity environment?
I've been spending a lot of time talking to children's hospital leaders over the last couple of months about their children's hospital infrastructure. And with this, I mean both their individual systems infrastructure, their footprint, their inpatient and ambulatory spaces, but then also the children's hospital infrastructure at large. We've been discussing 3 key strategic imperatives in this space. The first is to establish that tertiary quaternary center of excellence, your flagship children's hospital. This is the place where we need to make sure we have capacity to grow the high acuity and complex and niche services that only children's hospitals are equipped to treat. Then the second strategic imperative is being the director of a regional network that optimizes site of care, partnering across your region to have those alternative places that can manage inpatient pediatrics and serve that patient demand to be closer to home. What can we keep out in the community? What is low acuity enough? What is going to benefit the patient most to be close to home? And how do we create workflows and protocols that support keeping that care out in the community? And children's hospitals have that role. I always say you do need to be the director of the network in what care gets delivered where. And then the third strategic imperative here is building that ambulatory footprint. We are asked about this constantly. I'm sure my adult colleagues are often talking about ambulatory strategy as well, and working with children's hospitals to understand what type of ambulatory space do you need to build? What is the number one driver? What is your reason for building this ambulatory space? Is it to alleviate inpatient capacity? Is it to expand access? Having those conversations about your why and then building the model that supports that. And then, of course, doing all of the analysis that helps you understand what services actually need to go out there, how many, how big. I said 3, but I'm going to add one more, which is the subspecialty workforce. It is intricately tied to the children's hospital infrastructure that we can deploy. Do not lose sight of the challenges and opportunities that exist within the pediatric workforce. That's going to be critical to putting forth the infrastructure or the footprint that is best for your patient population.
If we think about some of the capacity challenges that in particular children's hospitals feel because of the brand recognition that exists there, sometimes it can be challenging to ensure that resources are being adequately deployed across care sites. How then can community health systems partner and think about working more strategically with those children's hospitals to be able to execute on some of those foundational strategies that you outlined?
You're spot on. They do need to partner. And this is not like a competitive situation. We can't only have inpatient access and subspecialty access in our big cities. We need community hospitals to maintain some level of skill set to manage pediatric patients close to home. This was especially important. Some of us are still scarred from the RSV season of 2022, where children's hospitals truly had no capacity and community hospitals were forced to keep patients that they really wanted to transfer. So we can't just rely on our children's children's hospitals, especially during respiratory season. It is not competitive and it is about remaining viable. How do we keep our skill set up? And often we do that by partnering with children's hospitals who may help us with workforce or help us with education. Those children's hospital partnerships are essential to the pediatric system of care.
The way that I think about it too is if you as an organization are treating the same level of acuity of patient today that you were treating prior to the COVID-19 pandemic, it's time that you assess your operational approach and start thinking about how you upskill your workforce and sites of care, because the reality is it's just not tenable to continue to provide a very middling level of acuity given the patient dynamics that are playing out.
We've got our pediatric inpatient portfolio, much like the adult side of SG2 does. We should all be looking at what is our patient mix, what do we want it to be, and how do we get there?
Just exploring further I believe, second strategy that you talked about, where it's improving those access points within the community. We have new consumer survey from the SG2 consumer survey that indicates that proximity as well as trust are the key drivers for where individuals choose to access care. It's more important than national rankings. Dionne, I'm curious, thinking about that data point, how should health systems evolve their approach to outreach and marketing?
We do see hospitals focus on how do we improve our national rankings, but interesting to see in the survey that it did rank lower as a factor into patient choice. But what we did find in the survey is trust was a really clear insight there, and that's from family and friends, but also from the pediatrician as well. Also in the survey, we saw that a high number of specialist visits were referred by a pediatrician, so it really just shows how important it is for children's hospitals to build that relationship with pediatricians because they do have a lot of weight in the patient choice. Another thing was that we saw patients also prefer care close to home. So there's about a third who would only be willing to travel about 30 minutes to see a specialist. So making sure to set up a way for outreach and care closer to home location, whether that's your own location or through partnerships with the community, those will be important, especially as we see consumer insights evolve and value trust and proximity more.
I want to further explore the capacity conversation. And in particular, how can we start to release that pressure valve? And are there opportunities to leverage things like AI-based care and workflows to make operations a bit more efficient? What do we think is going to gain traction first?
We're seeing a lot of good ways to apply AI to relieve some of that capacity concerns. We have a lot of different use cases, a lot of case studies, all the way from clinical to non-clinical, but non-clinical would also be supporting clinical care. These are like staff support robots. How do we automate administrative tasks? We are seeing interesting ways to adopt AI. It has a lot of applications from consumer experience, like having chatbots in different languages or to help translate documents, all the way to supporting the clinician. So a lot of like ambient AI for clinical notes, some things to help support the clinical capacity.
Yeah, start to augment the human capital wherever possible. It's very helpful. I want to shift us to a policy discussion, in particular as how does policy relate to birth rate? When I think about the work that you all do each year, one of the first steps that you undertake is building your births model. That serves as the foundation for so much demand that occurs over the course of the decade. So I'm curious this year, how are policy shifts beginning to influence capacity as well as birth rates?
Ooh, where do I begin? There's a lot of policies we could talk about for both capacity and birth rate. When it comes to birth rate, I will highlight two policy conversations in particular. The first is immigration and the deportation conversations that we're having. Reduced immigration in the country will impact workforce. It'll impact care delays. It will drive care delays. It will also impact birth rate. So we did a pretty cool analysis. We looked at CDC Wonder data at U.S. births by maternal nativity, either moms that were born in the U.S. against moms who were not born in the U.S. And we looked at this from 2016 to 2023. And from that full time period, both groups declined strongly, as we have seen overall birth rate decline strongly during this time period. But when we look at the smaller segments of time within that, we do start to see some diverging trends. So from 2017 to 2019, we saw births to mothers born outside of the United States declined more strongly than births to mothers born in the United States. And when we look from 2021 to 2023, We see an even more significant divergence here, where births to mothers born outside of the United States grew 8%, and births to mothers born in the United States declined 5%. We've looked at this data and said, well, I think the next few years are going to look a little bit more like 2017 to 2019. As a result, we declined our deliveries forecast more strongly than we have in years past. The other policy to mention as it relates to birth rate is the impact of abortion restrictions. We've seen now data post the overturning of Roe versus Wade that in states that have restrictive abortion policies, we see a rise in congenital anomalies, we see a rise in infant mortality. So even though our overall deliveries forecast is negative, we have some growth in our congenital anomalies forecast.
Very helpful. When we think about how these policy impacts are playing out across the nation, what should health systems be monitoring at a state level so that they're able to then adjust demand expectations accordingly?
Right now, there's still a lot of uncertainty. All that we can say is you do need to be monitoring this at the local level. The federal level policies are really not set in stone by any means. So you need to be monitoring locally. State governments are very involved. The other big policy impact is the looming potential reductions in federal spending on Medicaid and how that happens. Medicaid is a very state-specific program. If we get some kind of federal change to Medicaid, how that plays out will vary significantly by state. But right now, we just don't know what it's going to look like. So what children's hospital leaders need to do is scenario plan, understand all the different possibilities that could occur and how that would impact you, and also start to talk to your state level governments about what they plan to do. And are they going to make up the losses? Are they not able to do that? We're in this mode of scenario planning here when it comes to the policy landscape.
Super helpful, Rhae. If we put our creative hats on, I do think of the innovation impact factor as being perhaps the area of the forecast where we can be the most creative. When we consider advances in pharmaceutical innovation in particular, what are the top medications, drug therapies, therapeutic options that are coming onto market that could reshape care delivery for peds?
The emerging therapeutic landscape is fascinating in pediatrics, and we are fielding a lot of questions here. Everything from GLP-1s, yes, adolescents are accessing GLP-1s, to biologics, to gene therapies. I'm probably most interested in this biologics space lately because the rate of innovation is just insane and it's so vast. It's treating everything from more common conditions related to like dermatology and GI up through cancer. 5 years ago, I had no idea what a monoclonal antibody was, but now even non-clinical people like me can understand how they are changing the therapeutic options across the field. The story I'm most fascinated by right now is the bispecific drug blinatumomab and how that's changing the care path for children diagnosed with a certain type of leukemia. Blinatumomab has been in the cancer treatment toolkit, but at the end of 2024, it was approved for younger patients and for first line of treatment. So this really dramatically shifted how we attack pediatric leukemia. 10 years ago, it might have been chemo and maybe you could get a stem cell transplant. 2017 was an exciting year because there was the first CAR T-cell therapy approved for leukemia. This was still only used in refractory cases, but really changed the toolkit and really shifts care outpatient. Children's hospitals were delivering, it's intensive and it requires a lot of daily interactions, but they were delivering CAR T outpatient status. Now with this blinatumomab approval, we see this is a continuous drip delivered for 28 days up to 5 times. And a lot of that care is completely delivered inpatient right now. So tremendous demands on the hospital and a big shift. As we innovate in pharmacy, the demands on our system of care dramatically are impacted. And then, of course, gene therapies. I could go on about the gene therapy space, whether it's neuromuscular or hematologic in peds for hours.
Thinking about some of the broader policy applications as it relates to peds, vaccine administration is another area that has some key stories that are embedded into the forecast. Could you expand on the thought process and how you then figured out the timing of the vaccine component?
We have modeled the impact of the RSV monoclonal antibody in our forecast, but we haven't quite modeled the impact of the dynamic vaccine landscape that we find ourselves in right now. And this is a very important conversation, though. Tori, you talked a lot about capacity, and this is directly tied to capacity at children's hospitals. There's a lot of conversation from HHS related to vaccines. We're hearing headlines about changing guidance around COVID-19 for vaccines for healthy children, the recommendation there. We heard about the firing of the vaccine expert panel at the CDC. The important thing to point out is even in the absence of a specific policy to point to in vaccines, even without anything major changing, the damage has already been done. We see vaccine adherence at an all-time low in this country among children. We're seeing non-medical exemptions for vaccines at an all-time high in this country. The portion of children going to kindergarten with their MMR vaccine is much lower than it was pre-pandemic. This will push capacity at children's hospitals. This past year, we learned about measles outbreaks, measles hospitalizations. We've had one of the worst flu hospitalizations and flu death rate that we've had in several years. If children aren't getting their vaccines, there will be more infectious disease related preventable hospitalizations. That's just the science and the math of it. This will push children's hospitals' capacity, and our guidance to children's hospitals is we talked about trust and consumerism data. How are we leveraging using the trust that we have built with our communities, that we are the experts and that we think you should get your vaccines, and here's how easy we can make it for you to do.
It's so interesting to see this medicalization of care, even if the therapeutics are being performed or administered in an inpatient care setting. We're moving away from these incredibly invasive treatment options or options that just frankly weren't appropriate for the pediatric patient population. It's so exciting to think about the potential here for improving the health of our communities long term. Dionne, I want to turn things to you and talk about adolescent usage of the GLP-1s. We've seen a huge surge of adoption in this particular patient cohort. I'm curious, how should systems think about strategizing within this particular clinical program?
There are a lot of different treatment options right now. A differentiator for programs would be to create or expand their comprehensive weight management clinics that include both surgical and non-surgical treatment options. And to also have a multidisciplinary team that includes endocrinologists, dietitians, behavioral health therapists. Because in that same study that found that big surge, there was a 500% increase in dispensing of GLP-1s for pediatrics. It also found that endocrinologists were some of the main prescribers of these medications to pediatrics. So making sure that we have that connection to endocrinologists will be important as well.
Rhae, I know that this is a topic that you could really go down quite a rabbit hole with, but what are the highlights within this area?
The most important thing to realize is when we talk about gene therapies, it is also quite vast. There are a lot of different conditions treated in this way. These are being approved at a rapid pace right now. And there are quotes that the FDA will be approving 10 gene therapies a year, but they're very challenging to deliver. In pediatrics, we see hematology and neuromuscular conditions are where a lot of the approved gene therapies live. The neuromuscular ones in particular are interesting because they are a bit easier to deliver. They're often just delivered as an outpatient status infusion. Very different story on the hematology side. 2 gene therapies for sickle cell were recently approved. And this was groundbreaking because oftentimes the conditions that gene therapies can treat, it's a very small patient population. Sickle cell is a relatively large patient population. And there are a lot of patients that are in theory eligible for this curative treatment. The problem is they come at $2 to $3 million price tags. And in the current system, that means a children's hospital outlays $2 to $3 million a patient. The patient goes through a year-long process of assessing their eligibility. Finally, that day comes where the patient can access the drug. They're in the hospital for a very long time. And then after that patient is discharged, the hospital drops the bill. And then anywhere from weeks to months later, the hospital gets reimbursed. So there is just a tremendous amount of time and resource that goes into getting this patient this drug before the hospital sees any payment for it. And that's just one patient, one drug. So we've really got to find a way to be able to do this at scale. And I didn't even talk at all about all of the payer negotiations that goes into this. We've got to be making sure that we've got the contract in place, that the commercial payer, that Medicaid will reimburse for the $3 million drug. And we can't just do it for the commercial patients. We have to make sure our Medicaid's on board as well. So there's just a ton of work that goes into getting this set up. It's financial challenges. There are operational and logistical challenges. And all of this, we haven't even talked about just like the people emotional component of it and the patient and all that they go through. There are a few centers delivering this. Oftentimes, families are relocating to get this treatment for potentially a year. That's not very easy for a lot of people to do. After it was first approved, we wanted to see a lot of people getting this drug very quickly and curing their disease. And uptake has been perhaps slower than we would have liked to have seen. But I don't think that's because there's no interest or it's not happening. It just takes longer than any of us wanted to.
Yeah, the science is there, but the resourcing has to catch up.
Yeah, we really need a new model. We can't go at gene therapy like we do any other medicine. It's just too expensive and it's different.
Rhae, Dionne, thank you so much for joining the podcast today. This is barely even the tip of the iceberg in terms of the depth and breadth of the pediatric forecast. If you haven't had a chance to already, highly encourage you to go to our SG2 Intel website to view the pediatric webinar on demand, which was released in mid-June. Thank you so much.
Thanks for listening. If you like this episode, please subscribe, rate, and review us, and/or follow us on Twitter and LinkedIn at SG2 Healthcare. And if you want to talk more about innovative healthcare strategies, you can always email me at sg2perspectives@sg2.com. Finally, SG2 is a Vizient company, and there are a bunch of Vizient podcasts that you might like. You could find them at Vizient /podcasts. Have a great day.